So good morning. Let's get started. Thank you all for coming out. I know it's early, but it's really, we're so happy to have Dr. Sheila West this morning. She's so busy and travels a lot, and you'll hear about some of her work in Africa. But we're just really lucky to found a date for her. She's really let's see, an A-list, like, I don't know what the right analogy is, but it's so hard to get her, and we're really just so lucky to have her, so I'm glad you're here. Let me tell you a little bit about her from her bio. In the field of public health ophthalmology, Dr. West focuses on 3 research domains: the epidemiology of cataract, the impact of visual impairment on function in older people, and the epidemiology and control of trachoma. She's been funded by numerous NIH institutes, as well as the Edna McConnell Clark Foundation and the Gates Foundation. She told me this morning she's just finishing up a 5-year grant from the Gates Foundation and just received a new one as well, and a newly funded project by the National Eye Institute. She's been a principal investigator in numerous clinical trials, and she's going to tell us specifically this morning about conducting clinical trials in Africa. She's the author, again, of numerous epi studies as well as clinical trials, over 280 publications, and she leaves tomorrow for Tanzania. So, again, we're lucky to catch her. So, Dr. West, I'll turn it over to you.
Thank you, Kay. Well, it's indeed my pleasure to be here. It's not often we get to come across the street and give talks, so this is a pleasure. Being in the department, I wanted to have a few caveats before we got underway, and one is that I consider myself sort of a field epidemiologist and not a methodologist. I have wonderful people that I collaborate with, Beatrice Munoz and other statisticians who take care of more of the serious methodologic issues in our trials. I really like to think of myself as a field person. And because I'm talking about challenges to undertake clinical trials in Africa, I think you should know a little bit about where I'm coming from and also the disease that I study, so that what I say is put in some kind of context here. So first of all, I got my PhD from the Department of Epidemiology, and this was my hero when I was a student, Dr. George Comstock, who himself I considered a real field guy. He was best known for all of his work in TB, but was the kind of person that would walk into a group of students and say, I just got money to do this field study up in northern Alaska, who wants to go? And that kind of exciting opportunities were just sort of characteristic of him, and the kinds of things that he did and the sort of simple approaches that he took became the mainstay of how I wanted to conduct my career. Things like just ask the question, figure out how to answer it in the most appropriate population, and work with the best people that you can. The other inspiration I had, although far more intimidating than Dr. Comstock, is well known to all of you, Kurt Meinert, who I treasured because he was one of those who would tell you as a student when you were on the straight and narrow and when you were giving him a lot of BS. And I really appreciated his approach to kind of cutting through a lot of the fluff that surrounded research at the time. And I also really appreciated sort of how he characterized time. And I learned something I had never learned before with the concept of a flying pig. So I come out of that framework, out of the framework of people who care about asking big questions in public health with the most direct approach. So what do I work in? Well, I've been in Africa since 1986, working largely on trachoma. And why trachoma? And because of what trachoma is, you'll see some of how I've characterized the challenges that we have to deal with. So Why is trachoma interesting to me? It's the leading infectious cause of blindness worldwide. So one thing is it's an infection. It is, in fact, a chronic infection of the upper eyelid caused by Chlamydia trachomatis, which is better known in this country as an STD, but in most of Africa is still an ocular infection as well. It takes repeated episodes over a lifetime to end up with blindness or visual loss from this disease, and we'll talk about that a little bit more. So here's the global distribution of active trachoma, and in red you see the countries where districts have been confirmed. And although, for example, the entire continent of Australia is in red, what that means is basically that the native Aboriginal populations are those affected by trachoma, and that's definitely the case in all of these other settings. In Brazil, for example, also highlighted, it's really up in Amazonia or up in the north part of India. But you can see that the bulk of the cases, bulk of the burden of this disease is in Africa. So if you're interested in trachoma, then you go where the disease is. A lot of the experiences I've had have been from working in Niger, from working in Ethiopia, and primarily, and much of what you're going to hear from today, is all of the work we've been doing since 1986 in Tanzania. So what does trachoma actually look like? So you're going to get a quickie lesson here in the clinical aspects of trachoma. This is in fact, normal eyelid, has normal blood vessels, doesn't look swollen. If you flipped your lid, that's what it would look like. But if you were a child in Tanzania, and you took this child, for example, who's almost a year old, and flipped her lid, you would see something that looked more like this. And perhaps which one is the one that controls the front? Is it this one? Well, sort of. Okay, well, that's good enough, huh? The point here is that I can see, and I hope you can see, that up in here are follicles, are these round white collections of lymphocytes, the immune response to this infection, which characterizes this disease. And when it's very severe, it looks like this, where you don't see any blood vessels, it's so swollen, and you've got these white follicular dots. And when you get this over and over again is when you've got a problem. For example, in this woman who's been living in a trachoma village her entire life, has had this disease over and over, you flip her eyelid and you see something that looks like this, which is now a basket weave of scarring. This fibrotic tissue has replaced the normal architect in that eyelid, and because it is scar tissue, it starts to contract, it starts to pull eyelashes under, and you start to see something like this, where you can see here right on your left, those eyelashes that are now being pulled under and pulled down and are scraping across the eye. And at some point, that sets up a whole round of other complications leading to loss of clarity in the cornea and corneal opacification. So this is the end stage, the visual loss from trachoma. Now, what makes this really interesting is that it's really a community disease. This is what a typical community would look like in terms of the stages of these disease. So the active, infectious, follicular stage obviously peaks in the preschool children, drops off as you get older, and then you see that rise in scarring in yellow, and then the trichiasis in blue. So we're looking at really a community disease here. The WHO has set up as a goal the elimination of blinding trachoma by Get 2020 using a multifaceted strategy called SAFE, which is an acronym for surgery, antibiotics, face washing, and environmental change. So it's really targeting, isn't it, each stage of this disease. Surgery to turn those eyelashes back up and away from the cornea. Antibiotics to reduce this community pool of infection, and it's given to the entire community, and preferably a single dose of azithromycin. Face washing to interrupt transmission so that ocular secretions aren't passed so easily from child to child. And environmental change, ultimately, to reduce transmission. So there are lots of opportunities for clinical trials in the delivery or the refinement of the delivery in every one of these aspects of trachoma control. So hence the interest in working in this area, you know, the argument that you can't get international funding easily out of NIH is not necessarily true, because at least 3 of these trials have come out of the National Eye Institute, who has to be able to report to NIH that they are doing something internationally. So I help them with that responsibility. So in summary, and relevant for what we're going to talk about in terms of challenges, trachoma is a disease of communities. So except for perhaps clinical trials in new methods in surgery, where you need to randomize patients, really we're looking at interventions at the community level. So hence the need to do community randomized trials for this disease. Now, one can look at approaches to that, whether you look at randomizing communities, studying people, accounting for clustering in communities, or you do the analysis at the community level. Depends on, I think, the question that you're asking, and we'll talk a little bit more about that. But the second thing I want to have you take away is that trachoma affects the poorest of the poor, even within these resource-challenged countries where trachoma exists, is in the poorest communities and in countries that traditionally have very scarce resource for programs. So what does that mean? Well, not unlike, you know, HIV or malaria, which has a lot of money for programs. So there's a lot of competition for people like anthropologists and epidemiologists in these countries. Trachoma often has a difficult time attracting the kinds of partners that you would like, because they've been sucked up into a world that has far more resources than we do. And the research often occurs in areas where infrastructure is extremely weak. So some of the challenges I'm going to be talking about are trying to conduct what we want to think of as state-of-the-art clinical trials in areas that may not have the resources to support them in the way that we think of classically here. So let me start with some of the challenges, and I've got 5 of them to discuss with you. And the first one is identifying the right partners to partner with in country. And by this, I don't mean the classic sort of non-governmental organizations like Helen Keller International or Project Orbis or any of the other NGOs that are in these countries, because the country itself doesn't consider them as in-country partners. They are aid organizations, unless it's a local non-governmental organization. Now, they may be very helpful in helping you connect with the right people that you need to partner with, but they themselves may not be looked upon as a true partner. And you need a partner. You need people in country who can navigate often tricky, often very political, social, and cultural waters in trying to do clinical trials. Just the notion of doing research on a population raises a lot of red flags in places, and having true in-country partners, I think, helps sway political factions that you are serious and that you have partners who will look out for their well-being. And partners who can really provide the necessary cultural framework for the research that you're doing, that can help you understand why some of the data you collected wasn't what you thought. For example, we did and we have partners now who are doing clinical trials of trachoma in Niger. And you start looking at your data and realize that you might be seeing an effect, but you're not seeing an effect if the child is over age 2. And that's when your partner says, well, at age 2, that child is shipped away from the family, is now sent off to a grandmother's house or an aunt's house in a totally other village, totally other place, because that's the culture for weaning. And so you realize you've been assiduously following this child, but you didn't realize you were following them literally all over the district when you thought they were nested in the village in which your intervention was taking place. So understanding sometimes the framework that you're working in is critical, and particularly your partners can provide that. And I think it's also important to talk about partners who can share in the scientific endeavor and in the rewards from this endeavor. For example, in the picture on the left, this is our partnership in Niger, and to my left is Dr. Amza, who is a senior ophthalmologist, in fact, one of 2 ophthalmologists for his entire country, and he's in an academic institution, and he is very interested not only in trachoma, but also in the publications that comes from the research. And he's invested a lot of his time and energy in this. He speaks French, and so it's not necessarily easy for him to write the papers that we do in English. So what do? We share. I write, and he critiques, and we publish together, and we both come out with rewards from this system. And laying those out and putting those together is one of the parts up front of beginning, a trial. So identifying right partners in country. Then on to probably a more methodologic question, defining a community for community randomized trials. Now, they tend to be more sparse in this country, but not necessarily. But a community is often easier to understand. We have pretty good census blocks. We have pretty good demarcations of city or county lines or neighborhoods, things like that. But that is absolutely not the case in Africa. And what we know are these 3 things going into this. First of all, the community is not the same as an individual. A community is made up of individuals. So treating a community as though, even though that's maybe the unit of randomization, as though it were somehow an individual, is not to understand what is really going on in that community. And for one thing, we define a disease, a status, for a community. Community doesn't have a disease. The people in it do or don't. So it's the individuals in that community that define the disease status for that community. And hence lies what I consider a tension between the sample size of the number of communities that you need and the number of people within that community that you need to really represent that community. And as you read the literature, and I think this is not unusual for trachoma, malaria research and other research, the mantra that small clusters, and many of them are better, is to ignore what I think is the infectious disease nature of the disease you're trying to study. And for trachoma, if you look at, for example, the clustering of trachoma within a village, when you think that an ICC of 0.1 is large, we can be talking of ICCs between 0.1 and 0.8. So very large clustering. So here's an example of a small subunit in these communities. And I'm going to come back to this picture in a minute, because I'm going to give you a hypothetical example for a study. Let's say we want to detect a difference in trachoma rates between an intervention arm, something we're going to do, and a control arm. We're going to randomize at the community level. We expect the intervention is going to have a pretty sizable reduction. We've got power, betas and alphas, and we come up with about 26 communities per arm. and we're going to do the analysis at the community level. So we're going to characterize trachoma using surveys of randomly selected preschool children. So how are we going to carry such a study out? How are we going to actually do this? So I'm going to give you an example from the district that we do a lot of work in, Kongwa district in Tanzania. It's got about 75 villages now. There are 10 large towns that are on the road that really don't have trachoma, and the district has about 300,000 population. So you can see that these villages are pretty big. So we've got a choice of how we do this. We can take basically 2/3 of the entire district and randomize those villages in order to understand what children we should take. That is a monstrous job in census and mapping and randomly selecting children. But that is an opportunity. So here, let me share with you one village. This is Ngombe village, for example. It's got about 3,000 people, about 700 preschool children that we would study. So that's one of the 75 villages. Now within that village, we have what we call kitongojes. And these are sub-village units. They are actually pretty geographically distinct. They have between 600 and 2,000 people, depending on the village, anywhere from 140 to 500 preschool children. Because they tend to be geographically distinct in these widely dispersed villages, they may be units of randomization, in which case we could actually look at randomizing 3 to 5 out of these villages and cutting the number of actual villages that we have to go to by a good third. Well, there's also even further subdivisions. There are neighborhoods of 13 to 30 of these neighborhoods, or bolotse, per kitongoje. They have about 75 people and about 18 preschool children. So if you think about it, if we needed 52, quote, communities, very ill-defined what a community is, then we could almost get enough out of one village, randomizing those. And if you wanted to go to a real extreme, well, we've got anywhere from 15 to 30 households in each bolotse, which may have anywhere from 0 to 5 preschool kids. So some people define for themselves a community, not necessarily in publications explicitly, that they're going to study large households. And as such, you can see that they can almost get away with doing a clinical trial in one village, except for the fact that these households themselves can be very close together, as I've tried to depict here, and that if you try to randomize this household and this household into different units, of course the children interact, of course they get together, and of course that contaminates your outcome. There's even a question at the bolotse level. I mean, if you randomize this unit to one and this unit to another, and these guys are extremely close together, and this guy is closer to this than his actual neighbors to the north, then you have what I consider a serious problem of contamination of your intervention. Part of that is understanding the disease you're working in, but in our case, and again, as I say, I'm coming from a trachoma end, that's a serious concern. And in fact, there have been studies that find no differences because the community was too small and too close to an intervention community. The unit of randomization, a community, was not appropriate. So one of the questions we always ask is, what is the geographical spread of what we're going to call a community? Are they really distinct? So going back to our village here, our collection of villages, this was one of those kitongojis that I showed you. Now here is a bolotse. So yeah, maybe we could randomize this cluster. And then this becomes another cluster. Look at these guys. I mean, they're literally right across from each other. However, the next one of these, and you can start to see the distance, is quite a distance away. maybe it makes sense to take this cluster of households and make that a, quote, community, which then argues for the need for maps, for other detailed understanding of villages, and that is a distinct challenge, although more and more with Google Maps and other approaches, you can get that information ahead of time and not get a nasty surprise, towards the middle of your study. So what is another challenge? Managing institutional review board issues. I'm going to presume nobody in here is in the School of Medicine, so I can feel unconstrained to talk about our IRB. I'm presuming you have a much more knowledgeable and effective IRB than perhaps we do. But we also have a local country IRB. So the first question, of course, you'll be asked by the IRB, but you should be asking yourself is, does it even exist? Is there an IRB I can use in this country? And that varies. There's a very well-regarded IRB in Tanzania. In Niger, it happened to be a committee that was sitting in the Ministry of Health that met whenever anybody would provide money for lunch. So there's quite a variation in what the IRB is. But you got to find one or help them create one. Well, what does it cost for their IRB? I mean, we are fortunate in that our IRBs don't charge us anything. But in Tanzania right now, if I submit an IRB, it's $350. And depending on how many iterations I have to put back in to satisfy, there could be additional costs with each iteration. Knowing that up front is pretty critical. And what materials does it want? Interestingly, the kinds of things that you would think it wants, often it does, but often some of the materials have nothing to do with really ethical approval in the way that we think of as ethical approval. For example, the School of Medicine IRB doesn't particularly care if you are going to ship samples out or not. However, your local IRB cares a lot about that, and they want to know if you are going to build that country a laboratory so that they can build the capacity to do their samples in country. And that's part of ethical approval, because capacity building is considered to be part of the ethics of doing research in a country. So understanding where their concept of ethical approval comes from is often key to navigating a very difficult water here. Sometimes the things that are wanted seem very arbitrary, sometimes strange, and that's a lot of effort that you have to make with your partner to understand why it is that that's nested in what is called an ethical approval rather than some other particular venue. How long does it take? Boy, really good question. For our first Bill and Melinda Gates grant that Kay was alluding to, one of our partners was working in Ethiopia, and after 2.5 years, still had not gotten ethical approval. It was a 5-year grant. So we said, look, you got to either move it or we're gonna collapse it and just say you can't do it. Right now we're on 5 months, and this morning I finally heard for ethical approval from Tanzania, and that's one of the better turnaround times. So it can often take a really, really long time. So best starting months ahead. And finally, something that's a little sensitive, but I think it's worth bringing up, and that is, is their own IRB sensitive to its own populations? And by that I mean sort of rural Africa's culture. And here I'm going to give you an example. So, without naming a country. So in a particular country, we got back a comment that, and clearly from someone who had been had taken a nice set of courses, probably offered by the Hopkins IRB, and so had a whole checklist of things that they were really interested in implementing in their own country. And one of them was, are you going to ask for assent in children? Now, that's actually, in the area that we work, a really loaded issue, because children up until the age of 7 are considered strictly under the purview of their parents. Their parents make decisions for them. The children understand that that's the way it goes. There are whole rites that these cultures go through to have children become young adults, excuse me, or even adults. So within that culture, there are logical steps that are made in that local culture to graduate children in various stages of their life. So to be in a situation where you have just asked the parents, is it okay if we flip the child's eyelid, look at it, to turn around and then ask the child is to say to that parent, we don't believe you're really in charge. We need to ask this child. And to put the child in this horribly uncomfortable position of saying yes or no to something they just heard their parents say yes or no to, is to actually deny that whole process. And so to be asked by a local IRB to do something that is intrinsically insensitive to the cultural situation in which we were working was a very, very difficult situation. And in the end, we ended up not doing assent in children, at least under the age of 7, in deference to what we knew was in that population's culture. Now, let's go back to Hopkins. Here's the other side of managing institutional review board issues. And that's, we do have 2 people now from the School of Medicine, so I know this won't get back. Neither of them sit on the IRB board, so Jen. First of all, I think that the IRB at Hopkins has a real challenge in separating what is an ethical issue from what I consider a lawyer issue. It's a sort of a CYA issue, as opposed to really considering what are the ethical challenges in conducting this particular research versus what is the checklist of things that is going to cover us in case anything goes wrong. And that becomes nowhere more obvious than trying to get a project that's overseas in. For example, is it really ethical to list phone numbers at JHU IRB to call if there's a concern? I mean, 90% of our people don't have phones, don't have electricity for that matter, and calling the United States is not a trivial matter. So how ethical is it to say, if you've got a problem, here's your local, here's your IRB. We can give them a local IRB number to call, but this was required. Does rural Tanzania really need to know that Kennedy Krieger is part of Johns Hopkins? How important is that? But what does that do? All of that language just clutters up a consent form, just makes it so difficult for somebody to understand, what are you really asking me to do here? What do I want to do? I want to flip your lid. I want to see if you've got trachoma. I will tell you if you decide you don't want to participate or not. I will, you have access to all the health services in your country or any of the services that the district will bring in. That's kind of where we are. And with that, then, do they have any idea how expensive translation of all these irrelevant parts of the consent form are? So when you require us to do it and to translate it, that's hugely, hugely expensive. So the other question, of course, is the chicken and egg question. Who approves the study first? Because nobody wants to be first. So Hopkins says, we think it's okay, but what did the local IRB say? And the local IRB says, well, what did your institution say? So I would say about 50% of my time getting IRB stuff through is going back and forth between the two, saying, to Tanzania. Well, they're just on the brink. I think they're going to approve it. Okay, well, then we'll approve it contingent on that, but then you have to send us this. And I just spent about, it must have been 6 months navigating the IRB minefield between a joint research program that Wilmer has with a Saudi Arabian institution, so that our investigators would not be spending all of their time trying to do this chicken and egg thing, that they would be willing, one of the other of them would be willing to sign a document saying, this IRB is the IRB of record, and that we will abide by their decision. How easy is that? Wouldn't that be great? Took 6 months. So now we come to the part that I alluded to a little bit earlier, a real challenge in actually carrying out the research once you get underway. And the lack of infrastructure is really a very considerable challenge for researchers and actually for funders as well. There can often be sporadic electricity. So, you set up a nice schedule for how that trial is going to run, how the data entry is going to go, and when we're going to get the data. It doesn't happen, and you realize they haven't had electricity for 2 weeks. So the paper forms are sitting there, or the electronic devices that you've given them to do data entry in the field, they've not been able to charge because there's no electricity. Can you buy generators? Yes, you can buy generator. Putting a generator on a NIH trial grant is tricky business. And the other question, of course, it's not just electricity, it's the whole environment. I mean, trachoma villages are not just at the end of the road. There just is no road. And this village, this is a house at the start of this village in Niger, was about an hour-and-a-half walk. There was absolutely no way to drive there. And that's not atypical. So allowing for that and the flexibility to manage a trial in the context of needing some fairly rigorous deadlines and what am I trying to say? So as you've got a visit, you've got a plus or minus 4 days or 5 days or a week on either end. You may have to add a little more time for flexibility for that. Weather-related issue. But yes, roads and the world's best traffic jams on these roads. And weather issues. So this is an image I took out of the front of our Toyota, heading off to a village where the road from the previous rain had turned it into a lake, an impassable lake. So that village was absolutely not going to have a survey on that day. And in fact, we had to wait, either find another way around or had to wait until that lake subsided. So building in that flexibility and making your funders realize the need for that flexibility, is pretty important. So the need for basic infrastructure to do the research is also key, and that's often very difficult for funders. And the first one I would note is vehicles. The NEI has been actually pretty understanding with us, and the U.S. government owns like 5 cars in the middle of Tanzania now, because they recognize that without them, and you saw that the roads on this previous slide. I mean, we beat these cars up like crazy. That is part and parcel of what we are doing. Renovated space. If you really need an office, you can't go into an office space that, kind of looks like that. You need to have renovated space. You need to have some hope of electricity, some hope of desks and other kinds of equipment. That is less difficult because you can often build that into indirect cost for your site. But the other question is managing government. That's his local government expectations. Sitting allowances. So what does that even mean? That means what you pay people to come to meetings. So when your district medical officer wants to be briefed every 6 months on what's going on in his district and with your study, and he wants to bring his health assistants and his eye nurses and everything. You pay sitting allowances for everybody to attend that meeting, and you build it into the budget. And it's government expectations. That's a mandate from the government. Capacity building, which I alluded to earlier. These grants, all of them, should contain some statement about how you are building the capacity of the country you're in to carry out research on its own. And it may be as simple as training or providing a course on conducting ethical research. Or it may be as monumental as I said before, build me a laboratory where I can carry out PCR analyses for chlamydia. And you have to go, well, that isn't going to happen, and how can we help you get to where you want to go? Maybe we can train people or partner with people like the CDC or others to try to make that happen. And, not for outside of this room, but sometimes this calls for pretty creative financing, things that are called other things. But in the end, you do what you do in the context of the challenges that you have. So the final challenge, I think, is getting your results out. So I'm going to talk about trachoma. HIV is easier for many other things. Other clinical trials in Africa may not have the same issues, particularly if it involves mortality. Nobody actually dies from trachoma itself. They die prematurely from blindness, but that's ways down the road. So what happens when you've done your absolutely exquisite clinical trial, you've crossed every hurdle, half your staff has had malaria, you've got it out, it's well written, and you get something like this. It's really well done clinical trial, but it's not a subject of interest to our U.S. readers. So off you go trying to find another journal. Here's another one. This is really good. Editor, you have 2,500 words. Reviewer, please explain the socio-political structure of the country, how that affected the intervention. But you've got to explain your entire trial, so you have to do this in probably 10 words.
Poorly.
And,
one word.
Well, poorly. Yeah. So oftentimes, if the reviewers that have been selected are not necessarily those that already have an understanding, or quite rightly, they want you to cast your trial in the framework of the country so the reader can understand it, and you have this other limitation, that can be truly a challenge. And then what gives? What ends up giving in those situations? Or you often stick those things in you can look at it kind of online. And finally, something I think that I feel, but is also something I think is worth discussing, is what I consider the sometimes ethical imperialism when you get ready to publish in a journal. And what do I mean by that? In some ways, it's exactly what it sounds like. It is the imperialism of an editor who feels they have the last call on how you've conducted your trial. And probably the most egregious example of this occurred here at Johns Hopkins with investigators across the street who had conducted a clinical trial of interventions for HIV acquisition in Uganda. And this was a trial that took many years to get underway. It went through ethical review, through numerous organizations in Uganda, through the federal government, through NIAID, through the Hopkins IRB, and the trial went ahead. And then they published a piece out of the trial that looked at risk factors for acquisition of HIV in non-HIV infected partners. And it was published in the New England Journal of Medicine with an editorial from the editor of the New England Journal of Medicine decrying this as an example of a clinical trial that should have never been done. And why should it have never been done in their journal? And that set off a firestorm of letters and discussion, and led actually to what is perceived as the early dismissal of the editor of the New England Journal of Medicine over the decision to really blindside the authors of that paper. But there is some, I think at least, examples throughout those of us who do, and there's many in this room who do, trials internationally, that face both reviewers and editors who do feel that they have excellent, if not, but in fact do not, understanding of what it means to try to do studies in different cultures. So with all of these challenges, and I've listed 5 of them, I'm sure half of you in the room are going, well, I'm not going to do this. This is not very interesting. Why would I subject myself to all of this? So I thought I would conclude with, well, why do I do this? Why do I care about doing research on trachoma? And here's 3 examples. These are 3 studies with the outcomes that we found. The use of azithromycin post-surgery led to a 33% reduction in recurrence of trichiasis, a huge impact in the way that you can do surgery for this disease with a simple one-shot antibiotic right after surgery. Or clean faces in children. If you can get them to have clean faces, their odds of severe trachoma are 0.25 relative to those with unclean faces. And the more times you can keep them clean throughout the day, the less likely they are over time to have severe trachoma. Or a recent finding, you need at least 80% coverage of children with a single dose of azithromycin when you're doing mass treatment, but you can see a decline of 50% in infection after each round of MDA, so that you can actually start charting a trajectory of how long we have to keep doing this. So what you have is a disease where the trials you do can make an enormous public health impact. And because it's a disease that only occurs in very special communities, that's where you do it. And not the least of all is that you're having a real impact on people like this woman whose grandmother was blind from trachoma, and neither of her kids have it now, and she doesn't have it either. And that's why you do this kind of research. But it's not the only reason. You do it because you get to meet absolutely extraordinary people. You get to see them do absolutely extraordinary things, and you get stuff that happens to you that just doesn't happen anywhere else. So the challenges, yes, and they require a certain amount of perseverance and really good medical care back here. But in the end, I think the benefits, both from the research you do and the experiences you have, far outweigh those challenges. So with that, I will conclude and ask if there's any questions or issues that you'd like to bring up. Questions or comments? Yeah, Allison.
So, many of your trials are showing some really stunning results from these trials you've done. And have you been able to build into the trial a way to maintain that intervention after the trial's over?
Boy, that is a really, really good question. I would have to say yes and no. The no comes from, and it's not unusual, the immediacy of the finding in that particular environment often means the influx of more resources to make those interventions happen. And that is not an immediate outcome. For example, you look at the clean face trial. Let's look at that, for example. And that's an easy intervention. There isn't a mother on this planet that doesn't know it's important to keep her kid's face clean. I don't care what culture you're in. Women know that. And yet the resources to make that happen are highly variable. And if you're talking to a place, a community where it takes 2 hours to walk and get water, and you can carry about 25 liters of water on your head, then you're going to use that for drinking and for cooking. You're not going to, quote, waste it for washing. You have to figure out very clever ways to build that message in. So what's happened is that the notion of what it means from a community level to have a clean face was built into the school curricula. So every one of these villages has a school. So as part of what's taught in the school is the value of hygiene and the value of hygiene for any number of diseases. And so what we've seen and it actually tied into a curriculum devoted to avoidance of trachoma, is where that hygiene component is nested, is that over time, the rates of clean faces have dramatically increased. And with it has come, of course, the decline in trachoma, we think, as well. But it's taken probably 15 years to get the young girls who were part of that coursework into being mothers at this point. And we've seen a real attitudinal shift as well. When we first started doing this in the 80s, the women would say, well, yes, I know I'm supposed to keep my kids' faces clean, but, if I wash my kid, then I'm perceived as trying to be better than everybody else. There was a real social stigma to trying to be better than your neighbors. Now you go back, you ask the same questions, and the ones who are not washing their kids' faces are perceived to be putting the community at risk, that they are too lazy, they're too ignorant to do what's necessary for the health of our community. That attitudinal shift, I think, is the result of that intervention. So I think it takes a long period of time, not unlike what we know from this country, where the assimilation of results from trials can sometimes take a long time. For that, it's also not just the attitudinal shift, but the resources to allow those shifts to happen. So now, what do we know? I mean, we've got azithromycin donated for free for these countries. Something like 32 million doses provided last year. So yes, the drug is in country. We can make it available at the time of surgery. That can now happen. So yeah, I think that's a really good question. Yeah.
So I always find it difficult to explain to the control group that they may not have, or that some people may not have or get the intervention. I found that very difficult in the settings where I've been working, mainly in West Africa, to encounter difficulties in explaining that some may not receive the intervention and some will. So this understanding of science and of the necessity for a control group is sometimes not just not there.
Really good point. Yeah, the whole concept of control, or even what does randomization mean? The idea of flipping a coin or drawing something out of a hat. I mean, that's a really good point and probably another challenge. So, how I think because we have been in a situation where we have randomized whole communities, instead of having people who are trying to ask their neighbor, oh, well, how come you got 2 doses of azithromycin, I only got 1? By doing it at a community level, you're explaining that in this village, in other words, you and all your neighbors will be getting this regimen, whereas other villages are getting different regimens. Becomes an easier process to explain. And that's maybe one of the advantages we have from a community randomized trial. Unless the randomization unit is much smaller and within the village, then I absolutely agree with you that it can be much harder. And I think, we have had people who have questioned whether or not, for example, in one study we're doing in connection with the CDC, we actually randomized treatment at the Belozi level. So, and because we were in a village with trachoma below the standard at which you would treat mass drug administration. And so we had to go into a very lengthy discussion of, you know, at this point, the trachoma in this village is so low that we only want to treat sporadically. And so you may or may not be selected to actually receive azithromycin. And in some cases, that wasn't very popular, as you say. And we had one village where the coverage was really low, yeah, B. So depending on the unit, and as you say, when you get down to the individual level, I think that is a real challenge, and in our case may well lead to refusal on the other direction, namely, well, wait a minute, if you're not giving it to those guys, why am I having to get it? And that's, I think, a real challenge. Good. Well, thank you very much for your attention on this early Thursday morning, and good luck with the rest of this. Thank you, Kay.